I'm going to talk today about home care work. I was just saying to Bryony before, I feel that during the time of COVID, home care work has been quite invisible, as indeed have home care services. I'm not, however, going to talk about COVID. I'm going to talk about this idea of time autonomy and time to care, which comes up consistently in research around home care work and home care workers. So I'll just, here we go. Just trying to move there. Okay, so I'm drawing on emerging findings from an Australian Research Council funded project called Decent Work, Good Care, International Approaches to Aged Care. And our research aim, as you can see here, is to really examine how national policy, funding and employment regulation, operationalised through organisational practices and work design, shapes decent work and quality care in both residential aged care and also home care. And this is a cross-national study of 4 aged care systems: Australia, New Zealand, Canada. And in Canada, we're focused on Ontario because in Canada, aged care is provincially based, and also Scotland. And the other CIs in the project include Donna Baines, who was formerly at the University of Sydney. She's now at the University of British Columbia, Ian Cunningham from Strathclyde, and Tamara Daly from York in Toronto. And our project manager, Wendy Taylor, has assisted me greatly with the data analysis from some of our case study work for this project for this presentation. I'd very much like to acknowledge her contribution. So this is the question that I've posed in this particular seminar. So how do Australian and New Zealand long-term care systems and providers shape home care workers' time autonomy and time to care? So what I mean by time autonomy is the control that workers have over their own time in terms of the hours of work and the scheduling of those hours, and the control they have over the time allocated to care for clients. The focus of this analysis is looking at the macro level, the policy and regulatory level, and then at the more meso levels, the organisation of work in home care, and particularly focused on how the interactions between those levels within 2 very different national contexts shape this temporal experience of the work of home care. And basically my argument is set out here that compared to the Australian home care regime, the New Zealand home care regime, despite historically far poorer employment rights architecture, provides the conditions for greater worker autonomy and time to care. And reasons for this, which I'll flesh out in the presentation, involve that a devolved responsibility for aged care, empowered agencies, and the fact that individualisation is less developed in New Zealand. But at the organisational level, home care organisations have a crucial role to play in enabling time autonomy and time to care, in the case of New Zealand in particular, and or protecting workers from system constraints on time autonomy and time to care in the case of Australia. But there are inevitable gaps in those protections which allow the risks and inadequacies of the home care systems to be shifted onto workers. Okay, so in terms of I keep going to click the wrong thing on my computer here. So in terms of the key theoretical framings, the whole project's conceptual approach is framed by political economy approaches, which enable us to better understand how economic and political institutions shape and interact with gender regimes, with care regimes, with employment regimes. But in particular, it draws the attention to the importance of national context. We also draw on labour process perspectives in highlighting how home care regimes organise care work, and looking, say, at the labour process, which pays attention to the ways in which workers' time autonomy is shaped within that regime by employers, service users and workers. Scholarship and on the role of employers in social care, particularly from the UK, provides a useful lens for our analysis and highlights how time autonomy can be constrained through fragmented time schedules and rostering practices, and enhanced by addressing those issues and enabling workers to have secure, predictable and sufficient time to do the work of care. So the project methods are broadly these. It's involved regulatory mapping of in this case of Australia and New Zealand, including the national level long-term care policy that provides a context for the provision of home care services. We also draw in on here on 3 in-depth home care studies that were conducted in 2018 using a rapid ethnographic approach. And our version of this approach makes use of 5 to 6 insider researchers who've got the national expertise and outside researchers who've got expertise in other care systems in undertaking organisational care studies. And they're conducted over a relatively short intensive period of time of up to a week on the ground to gather data from multiple sources, including through formal interviews, shadowing workers, informal interviews and discussions, etc., and looking at internal documents and mapping of the policy documents. It really allows us to draw the links, if you like, between the everyday life of aged care work, the organisation in which it takes place, and then the national and policy and regulatory context in which work is done. Now, each of these 3 case studies, I'm going to draw on 3 case studies, were recommended to us by various sources in these countries as generally they had a reputation as good employers, providing decent work, if you like, and also as being responsive to their aged care clients. So this is a brief snapshot. We've got the 2 case studies in New Zealand. They were covered by, and I'll go into this in a moment, they're covered by different health district boards, both of them mid-sized organisations, with the first case study located in a suburban area, servicing a socio-demographically diverse population. Then the second case study is an ethno-specific home care service. It's a single site service providing home care, in fact, across 2 district health board areas. The vast majority of staff are from the same ethnic background as the clients. And it operated in a very collaborative way, so that while the workers did the main work of home care, the home care workers, they were very much assisted by field coordinators who are involved much more closely than you would see in Australia from team leaders, for example, in home care work. Our Australian case study is located in a large, long-established faith-based not-for-profit organisation that's got multiple sites. We were just in one major site, and it has been experiencing very strong growth because of its particular location in a rapidly growing area on the outskirts of a large metropolitan city in Australia. But I want to stand back and to kind of put these 2 systems before I take the deep dive into the case studies, so you can actually see some of the differences between Australia and New Zealand's organisation of home care. So if we have a look at this OECD data, first of all, just in terms of demographics, Australia's approximately 5 times the size of New Zealand, but we've got very similar age profile. 15% of our populations are aged 65 years and over. Differently organised in terms of the relationship between residential and home care. In Australia, home care clients make up 50% of long-term care users, whereas in New Zealand that's 72%. And in OECD comparison, Australia is the outlier here. Most long-term care systems are these days much more weighted towards the delivery of home care. Australia's moving towards that, but at the moment, as you see, we're 50-50. Now, these the percentage of the population using at-home care is different, as you can see in both countries. I've also put up then the female population, which is interesting. It reflects the longevity of women, perhaps. But you can see that New Zealand has simply a larger proportion of the population accessing the formal home care system. Then if we have a look at the population 80 plus, you can see this is very much intensified. Not only is there a dramatic jump in terms of clients once you get aged 80 and over in terms of those who are actually accessing the formal home care services, but you can see the huge difference also once again between Australia and New Zealand, because in New Zealand, if you look at just women aged 80 years and over, almost a third of them are accessing home care services. And finally, I'd like to just have a look at the formal, total formal home care workers. So in the second last column, I've got the total formal home care workers. Then from those, the personal care workers. So the difference between these 2 are the registered nurses and the professionals who are involved in the delivery of home care, as you'll see that there's very little difference. We have data available for total, that is a head count. For total formal care workers, the OECD provides full-time equivalent figures. And so you can see that once again, there are real differences if you just focus on the full-time equivalents between Australia and New Zealand. And also the trajectory of the ratio of formal care workers in the at-home system is very different. In New Zealand, we've actually seen a growth in the FTE in delivery of at-home care, whereas in Australia there's been a drop. And in this case, New Zealand is the outlier. Across the OECD, perhaps counterintuitively, we've seen a drop in the proportion of formal care workers at home. We've also seen that in residential aged care, but it's quite marked here in formal care at home. So between 2012 and 2016 in Australia, for example, we dropped from 1.6 FTE to 1.1. We only have headcount figures available from the OECD for personal care workers, but then you can see those in the last column there. Okay, then in terms of the kind of the system, well, as you would know, Australia has a national centralised system. It underwent major reform in 2013, and from 2015, consumer-directed care applied to what are known as home care packages. We still have obviously other forms of home care funding, but this is the major one and it's growing. And this is where an annual amount is provided for a client rather than block funding based on the number and needs of clients. It's increasingly user pays. There's a daily fee for all users, plus an additional means tested fee depending on income. Clients are referred to these days as consumers, and they also have to pay the agency's administration fees, which are charged by the agencies, previously block funded by government, and between 25% to 40% of the value of the package. And when you actually have a look at the itemised accounts that clients receive, they're charged for everything. And the work in lots of ways, and there's lots of discussion about this, has become much more task-based because it's easier to charge for specific tasks. As you would probably aware, with the attention that the Royal Commission into Aged Care Quality and Safety has given it, there's a very long waiting list for aged care packages. And even despite the issue being raised in the Royal Commission's interim report last year, the Commonwealth has still got a long waiting list for people waiting for packages. Up to 2 years is the waiting time for a level 4 package. And there are also other issues which I'll just briefly mention here. There's a significant and largely unexpected hoarding, if you like, of packages. So a lot of older clients are concerned about having enough money in their package if they were to get iller, and they've been hoarding large amounts of money. This is a huge liability issue, and the Commonwealth is now asking the providers to return these funds at the end of the year. But I think it highlights perhaps a bit of an issue to do with consumer-directed care. Now, New Zealand's system is sharp contrast. You have a devolution from the Ministry of Health. So yes, it's nationally organised down to district health boards, which have different priorities and funding models. The official Ministry of Health policy for the district health boards prioritises service integration, communication and collaboration. It is also seen as fragmented. There is wide variation, interestingly enough, allocated to home care between geographical areas, and a wide variation of in services. And for example, across the 20 district health boards, the funding by them for home care varies between 1.8% of their total budget to 3.2%. However, there's some key system differences. Personal care is free in New Zealand. It's mean tested in Australia. Home care only is charged for where it involves just domestic work or just housework, and it's still then free to people who are eligible for social security, basically. Interestingly, at both our case studies in terms of waiting lists, It does vary between DHBs, but in both of our case studies, there are absolutely no waiting lists whatsoever. Okay, well, so other key differences between the systems are around the marketisation of home care. So these numbers here include providers approved to deliver home care packages in Australia or that have DHB contracts in New Zealand. Australia's home care system, as I've said, has been going through a substantial change since 2013. We've seen a decline in the proportion of not-for-profit home care providers. And since the introduction of CDC in 2015, there's been a sharp growth, as you can see there, in the number of providers entering the market. They are mainly smaller providers, and more of them are not-for-profit. So in 2019, out of 928 providers, 36 were for-profit providers, compared to just 13% back in 2016. There's been concern expressed by the Royal Commission, including by the Council assisting last year, which reflects concern about the rapid transformation of the sector and the fact it was actually revealed to the Royal Commission that the Department of Health had only 3 permanent staff across Australia vetting new home care provider applications. And there's also outstanding numbers in the Royal Commission's interim report. It draws attention to the outstanding numbers of new home care providers waiting for formal accreditation. Now, in New Zealand, I'll just maybe move on to the next slide. So we've got 2 different models here. Australia's home competition is at the heart of the Australian consumer-directed care model. So together with the individualisation of services, that is the packages belonging to just the particular client, this has really created some volatility in the home care sector. It's very difficult for providers, therefore, to plan for growth, and some services that have a good reputation, like our Australian case study here, are experiencing really rapid growth and turnover, losing and gaining clients. And to cope with growth, they need more workers or existing workers to increase their hours. And it did, this particular organisation, its managers talked at length about going from this much more cooperative way of organising home care in this particular geographical area in which they're located to being then a competition for clients in terms of attracting clients with the packages. In New Zealand, under its alliance system, and it works particularly well in one of the DHBs in one of our case studies, the contracted providers share referral information and share incoming clients. And so they know clients as providers and can respond to changing care needs, partly because the District Health Board places a direct assessment role within these providers for non-complex clients, which are seen as being very positive here. And you can see a comment here from the first New Zealand case study talking about how shocking it was at first to have to give away this sense of control. In this particular DHB, there are 4 home care services contracted to provide home care services for the whole geographical area, and there's been enormous cooperation now developed between them. There's 2 for-profit and 2 not-for-profit. And what's really important is with the referral. So if I'm in this DHB and I'm looking for care for my mother, I will simply approach the DHB and I will be allocated to home care service number 1, and then the next person to number 2. But if I prefer to be, because my neighbours or my friends say home care provider number 2 is good, then I can ask to be switched to that. But it's a way of really spreading the load and evening out the more complex cases. Okay, so I think I might have just switched a slide. No, I haven't. Okay, I'm wanting now to go to some of the working time policies that these 3 different organisations had put in place. And this was in terms of this idea of kind of both protecting clients, but also in particular protecting workers, because that's what I'm focusing on here now. So in the general service in New Zealand, they had arranged for paid monthly meetings for support worker teams so that workers would come, this particular provider was organised over sub-geographical areas, and workers in that team would have these monthly meetings which were on paid time. They would come together, they would talk about issues arising, they would sometimes, because they were organised in this geographical way, they would talk about issues to do with clients, etc. This organisation also provided very responsive support to workers out in the field. So if there are any difficulties, for example, when a home care worker got to somebody's place, they would be immediately encouraged and be on the phone to the particular person in charge of their work unit, the line supervisor, and if necessary, that line supervisor would immediately come out. What's really interesting is the capacity that workers were encouraged to develop to respond to clients' needs and preferences, and I've got an example about that later in the presentation. In terms of the ethno-specific agency, they had very interestingly decided one way to professionalise their workforce. They drew their workforce from the same ethnic community that they were servicing. And a lot of these workers had not completed school, so they really saw there was a need to really develop lots of training support, and that rather than having short, fractured time, they would create full-time jobs, 35 hours plus, to help professionalise the workforce. So they ended up with fewer workers, but more regular workers, and then they had a reliever pool to reduce schedule changes, which they saw as important for workers, but really important for client continuity. They also had very strong relationships with their DHB assessors and regular client reviews, which could also be initiated by home care workers if they were concerned about deterioration, for example, in the condition of a particular client. They would immediately call, and a DHB assessor would come out and reassess that client. The field coordinators, as I mentioned before, played a strong pastoral role with the workers. They really helped the workers manage time and particularly care issues with their clients. Often the clients were living in large multi-generational family households, and it was sometimes hard to have a demarcation between the work that the home care worker was there to do with the particular client and perhaps the broader family. With our Australian home care case study, they were very interesting. They did what we've called workarounds of consumer-directed care. So what they designated home care workers, one home care worker was designated the primary care worker role for particular clients, which involved them taking part in the review of clients' care plans, which also encouraged home care worker autonomy, but gave them a real sense of ownership and often pride in terms of the work that they were doing with particular clients. Managers also, very interestingly, managed the whole issue of consumer-directed care, which is understood by lots of people as meaning that the client just says, well, this is what I want and you will provide it. They would often then negotiate this with clients. So they could say, for example, look, you can have the same worker on the 3 days a week that we're providing a service to you, or we can give you a regular time, but you might have 2 different workers covering those 3 time slots, which actually works then to stabilise the worker rosters. So they weren't doing, as a lot of home care providers doing, just simply whizzing their workers round to enable the meeting of what was seen as to be absolutely fixed in stone client needs. And the managers talked a lot, and the team leaders talked a lot about talking with families and saying, well, look, you can, I know your mother really likes Mary, but if she wants to have her, then yes, she can have her at 8 a.m. 2 days a week, but on the 3rd day, she won't be able to be there at 10. Will that be all right for you? And more often than not, they said that people would agree to that. As I said before, the client demand, very much due to their geographical location in this growing suburban area, really provided this particular agency the opportunity to offer full-time work. This is something really sought by a lot of home care workers. Home care is distinguished by huge underemployment. People are typically employed on very short part-time contracts. Their hours might be flexed up as needed, but they're always wanting more hours. It's estimated around about 40% of home care workers want or are available to work more hours than they currently have. So then having a look then at our New Zealand case study, this is from an observation of one of our team who'd been shadowing a home care worker across 6 clients, and it's very much about developing this impression, having a look, being with the worker, talking to the clients, talking with the worker about whether or not there was time factored into the visits. And certainly in the 2 agencies were in New Zealand, this was also the case at New Zealand case study 2, there was a sense that the time that was needed to be able to shower somebody, to be able to make their bed, organise their breakfast, there wasn't the sense of rush that you sometimes see in Australian home care. And in this particular example was the one I referred to before. This particular client had macular degeneration and was pretty capable, a 95-year-old, of looking after herself, but it was a bit hard for her to organise food. And this home care worker realised that, yes, the Meals on Wheels was working brilliantly during the week, but in fact she had no food on the weekend. So she notifies her agency brings out the assessor, and they agree to allocate more time so the worker can take the client shopping on the Friday, which is also a social visit, but also to make sure that there's food in the fridge for the weekend. So that's just an example of that very responsive system there. This is also at New Zealand 1, and this is trying to balance scheduling and guaranteed hours as part of the historic New Zealand aged care equal pay settlement back in 2017. The New Zealand government, the DHB's unions and providers reached a funded agreement that required home care workers be guaranteed regular hours of work based on the hours that they'd usually worked. And that came with a pool of an additional $1 million to providers for implementation costs, and top-up funding for unfilled guaranteed hours. So the idea is that rather than just paying a worker for 1 hour to do a client here and then a couple of hours later for another hour, that you provide them with 4 or 5 consistent hours of work. However, while that was a wonderful idea and a wonderful innovation, it wasn't fully funded by the government. And so it left agencies wearing the cost of the guaranteed hours, which often they would then pass on to workers. So this particular worker, who I have to say was not necessarily typical of the others we spoke to, but her concern here reflects how the imperative to provide workers with guaranteed these regular continuous hours without government funding can impact both negatively on workers' schedules, certainly her schedules, and worker continuity for clients and thus service quality. So here she's saying, well, this other worker, Rhonda, needs hours to make up her guaranteed hours, and so then they've taken hours from this particular worker and given it to Rhonda. So that's part of the issue here. In New Zealand, a striking feature for the non-New Zealand researchers, we had a New Zealand, well, none of the chief investigators in this project from New Zealand. We had a terrific New Zealand research assistant who was able to provide us with the insider information on the New Zealand system. But for the non-New Zealanders, we found observing workers compared to observing them in Australia was that time to chat was seen as an integral part of the work of home care. And it was seen as very much as providing the opportunity to both connect and establish a relationship with client, which we all know is so central to good quality relationship-based care. So if we turn, there's also at this New Zealand, at this second ethno-specific organisation, it employs most home care workers as full-time, as I said before, as a practice to professionalise the workforce, but they do rely heavily on relievers. And in this particular case, this worker has a base of 35 hours, but as a reliever, she always ends up working 6 days a week. And I think her lovely description here of the just in cases, so she's got to organise her daughter into out of our school care, highlights how scheduling changes shifts the risks and unpredictability of running home care onto workers and their lives outside of work. In the Australian case study, this particular organisation really works hard to create some space in this quite constrained consumer-directed care model for worker autonomy, meeting the client's needs during a visit. And very importantly for workers, it makes clear that the client is the focus and supports workers in that. And this is, examples of negotiations which happen inevitably in home care. They do too, obviously, in residential aged care, but they're quite acute in home care, between who's really the client. Is it the client, the older person, or is it the family? And often workers will get caught in the middle here. But this particular agency very much has a sense of having the workers back, and that the client is in fact the older person. And so it's quite proactive in working with family members. So in both these examples, both the worker and the general manager highlight the tension between workers and families that come up in home care, as I said, which has really intensified under consumer-directed care, with its promise of choice and control, because then the issue becomes whose control and whose choice. Is it the client or the family, or indeed the systems? Also, with our Australian-based case study, looking here at this idea of time autonomy. Now, as a bit of background to those of you who may not be as familiar with home care, there is a practice in Australian-based aged care called availability. So most home care workers are employed on a permanent part-time basis. They, in order to, for example, to be have minimum hours of, say, 15 or 20, they have to say that they'll be available for hours outside of that. So if you're given a minimum 15 hours a week, then you might have to be available for up to 20 hours a week. And you can specify when this is. So, but it's really led to a stretching, if you like, of worker flexibility, which takes advantage of silences in the relevant industrial award. So the industrial award that covers home care workers is the Social Community Home Care and Disability Services Award, and that sets home care worker minimum conditions. And in this particular case, the interview with the scheduler is saying, well, okay, worker's sick. So immediately what the home care scheduler does is to go and see what care worker has green or availability. So where the worker has said, in this example, they're prepared to be available from 7, then the scheduler immediately assumes that this particular worker will take on this work. So that can often be an issue for workers, because if you're rung up at 6 a.m. in the morning and told, okay, you've now got this visit with Nancy at 7 o'clock, that then leaves the worker having to scramble. One could argue, well, they've said that they'll be available. Unlike other personal services workers, be they paramedics, be they firefighters, who are paid availability allowances, in Australia we don't pay workers any additional remuneration at all for being available. And it's an interesting contrast with New Zealand, where in fact home care workers who are expected to be available outside their schedule hours are in fact paid an availability allowance here. Okay, and also in Australia, this is a quote from an interview with an area home care manager who's talking about, coming back to this issue about planning for growth. This particular organisation is interesting. It has an enterprise bargaining agreement. Those of you who don't know, you might be shocked to know that home care workers in Australia under the industrial award are not required to be paid for their travel time as they drive from client to client. Their travel time is their own time. They are paid a small fuel allowance, but not for their time. This particular organisation has an enterprise agreement, and in its enterprise agreement, as you'll find in enterprise agreements where home care is provided in places like Victoria through local government, paid travel time is part of it. But in this particular example, the home care workers talking about, and this is in a very busy, growing population centre, so traffic is a huge issue, that the enterprise agreement provides a 30-minute travel time between clients, but in fact, the practice of this organisation was to give them 45 minutes, and a bit of the backstory here is this is because often what it would take as you drove from client to client through particularly heavy traffic times, particularly early in the mornings and around school knock-off times. But because of the growth, they've, and to try and squeeze more clients onto rosters, they've in fact cut down the travel time for their workers down to 30 minutes. Now, they're already paying an above award entitlement, but in fact, the 45 minutes that they were giving them isn't an enforceable right at all for the home care workers. And it's an example of how good conditions can be chipped away through the kind of volatility that's certainly been created in the system through the introduction of consumer-directed care. Okay, so I suppose my argument here is that the spatial arrangement in terms of how involved and how decentralised a system is really important. So in New Zealand, we've see its proximity and responsiveness to providers supplied through this devolved system from the DHBs, this devolved autonomy from the Ministry of Health to the DHB to the agency empowers the agencies. And the case particularly of our first case study, direct to the workers, and the case of our second New Zealand case study via the care team leaders, which is a slightly more paternalistic system. There is greater trust, interestingly, of providers by the DHBs, and we've also done interviews both with the Ministry of Health and the district health boards. And so, for example, in our second case study, there's lots of descriptions about how they're collaborating with the other providers. The home care providers get together to discuss where they might have shared clients or might share people of different members of extended families, and there's much more the sense of collaboration rather than competition. In Australia, you've got through this very centrally organised system a distance from providers and a lack of responsiveness, arguably, by the Department of Health. It's encouraged, if you like, and we see this in the Australian case studies, workarounds of some of the inflexibilities of consumer-directed care. But this particular organisation can do that because they're in a particular area where they've got increased demand. But they've also, and they've got that demand because, as I said, they're in the fast-growing suburbs. And it's a large organisation, so its economies of scale in terms of the number of workers it has means that some of the inflexibilities of consumer-directed care can also be modified. Another factor that's really important is the degree of individualisation of home care. So in New Zealand, the fact that personal care is not means tested, it's also more outcomes focused. The care plans are very explicitly outcomes focused, and it's funded on the basis of needs of a group of clients in each of our two case studies. So they're not receiving a separate allocation for each of the individual clients that they're providing services to. And once again, also having the location of DHB assessment staff in the agencies can support responsiveness, and it facilitates the involvement of workers in responding to changing clients' needs in terms of the time and the care that's being provided. As I said before, in Australia, the consumer-directed care really produces task-based, itemised and time-limited home care set within the confines of a package. And it's very much this almost billable hours system, which doesn't count the work that's undertaken to support the work of home care, if I can put it like that. It really pushes it onto agencies, workers and clients. And care plans are relatively inflexible, although certainly the Australian home care case study really tries to give workers more say and control than envisaged in consumer-directed care by allowing them through this primary carer role to be involved in the review of clients' care plans. I think our study also underlines that the role of the organisation, the role of the provider in buffering or shifting time inflexibilities and rigidities. So the risks of home care service delivery are still delivered ultimately onto home care workers, even in New Zealand, where the lack of fully funded guaranteed hours left both case study organisations there moving rosters around to minimise the non-funded cost of guaranteed hours. So this remains, I think, still a major problem with both systems. But look, I'll stop there. I'll see my time is up, and very happy to take any questions. Thank you.
Fantastic. Thank you very much, Sarah, for that very informative presentation. We now have some time for Q&A. If you have any questions, please submit them now through the chat function. Alternatively, if you would like to ask your question in person, you can turn on your camera and microphone and we'll call on you in time. So Sarah, if you could stop sharing your screen, we'll be able to look at everyone.
Okay, thank you.
Excellent. Well, we already have a few questions coming through in the chat function. So the first one from Anita is, what are the training and education backgrounds typical for home care workers in New Zealand and their ongoing training opportunities? For example, in dementia care.
Yes, well, I'll start with that one first. As part of the equal pay settlement, it's been quite a profound settlement in New Zealand. The new pay structure for home care workers and residential aged care workers, the frontline workers, is based on levels of qualifications. So the entry level is you have no qualifications. There's certificate level 2, you're the next step up. That's equivalent to our certificate level 2. Certificate level 3 is the next step. And then certificate level 4 is the top step. And typically, as in Australia, they're very similar training systems. The dementia specialty is in level 4. So that it's a very interesting system. It's produced some kind of perverse outcomes, which I could go into perhaps at another time. But as soon as you've done that training, you're entitled to be paid at that higher rate. So a lot of organisations, so you're moving in New Zealand, it was partly because it was recognised that aged care workers, but home care workers in particular, were not particularly well trained, and good training for workers was central to providing a good quality, sustainable care. And so that's why the training and education is seen absolutely as part and parcel of it. What was fascinating to us in this ethno-specific home care organisation, where, as I said, workers typically hadn't finished school, they did an extraordinary amount of face-to-face training and teaching to get workers ready to be able to take on the additional training for certificate level 3 and certificate level 4. So that was seen as incredibly important, and once again was quite empowering. I've seen a very different system in Scotland where workers have to complete equivalent of a certificate level 2 to remain in the system, and there's just expectations that somehow they get there. There's really not much assistance. This particular organisation provided a lot of assistance for its workers getting to the level of those particular qualifications. So this just. Will I go on to the second part of that question? Because I can see the thoughts of experience on the communication between them and their clients. Well, you know, it's interesting. Sharing of mobiles is a mixed blessing. Some workers in Australia I've spoken to are very concerned that their agency will give their clients their mobile numbers, because they'll often be contacted by the client or the client's family out of work hours when it's not part of the work. So it is interesting at both of these, and these are just 2 home care organisations we spent time at. In both of those, mobile phone numbers are not shared with clients. So the client can communicate through the worker, and the worker to the particular agency, or the family directly to the agency, but no, phone numbers aren't unshared.
All right. So moving on to the next question. I imagine these differences would impact on worker satisfaction with their role and the client and family satisfaction with the service. Did you look at these outcomes?
No, we weren't looking at those in particular. It was interesting in our experience in New Zealand, because in New Zealand they had the experience till 2017 of working in a largely deregulated system, having basically 0 hours contracts, just getting work where they were able to quite an organised system with guaranteed hours. and substantial pay increases. I mean, these were significant pay increases. The lowest rate before the settlement was around about $14 New Zealand an hour. It went up immediately to 19, and then it's by 2021 the top level will be $27 an hour. So this is for some workers it made an extraordinary difference, particularly if they were able to get hours of work. So the workers were satisfied with that. Workers were the New Zealand workers we spoke to were satisfied with the fact, because like lots of home care workers have been at a number of agencies, they were satisfied with these particular agencies that they had the chance to advocate on behalf of their clients. This is something that home care workers feel very strongly. The two things that in all the surveys that come up that home care workers dislike about their work is, number one, the pay, and secondly, time to care. So in terms of pay is something that Australian home care workers still complain about, and they still are complaining just in some recent surveys about time to care. But we were talking with, our project wasn't oriented to measuring client or family satisfaction. We were talking incidentally with clients, and in some case clients' family members, but that wasn't a central focus. We're much more focused on the work that was being done.
All right. The next question is, hi Sarah, do you know any differences in complaint processes between New Zealand and Australia?
I have to say, I don't in detail. I do know that in both countries there are dissatisfaction about this, but talking with the managers in and also the Ministry of Health and the DHB interviewees in New Zealand, the proximity of the DHBs to the providers does mean that issues get sorted very quickly. Now, these also relate to system issues that arise when there's small changes in policies, particularly around the way things are funded or what's being assessed, but they also rely on client complaints. I mean, that they also can deal with client complaints. In New Zealand, as in Australia, all complaints are supposed to be formally made and formally responded to, but I couldn't really say, you know, if there's a huge difference in complaint processes.
All right, well, that looks like the end of our questions that we have here. Please join me in thanking Sarah with your clap reactions. So next week, we'll be hearing from Associate Professor Lucio Nacarella, who will be presenting The Built Environment Matters to the Aged Care Workforce. So please join me next week on Tuesday, the 11th of August at midday. And thank you very much for attending our Seminars in Aging program.